Hey guys, welcome back to another rapid update. In this video we're going to talk about health technology assessment in South Africa, the methods guide published on the 14th of June, which will be used to inform the selection of medicines for inclusion on the National Essential Medicines list. Stick around. Hey guys, welcome back. So the purpose of this video, it's part 3 in a series of recorded videos speaking about the publication of the Health Technology Assessment Methods Guide on the 14th of June. In this part 3, I'll be talking about the supply and demand of health economic expertise and skills required to be able to undertake health technology assessments in South Africa. In part 1 of this video series, I spoke about the principles as they relate to health technology assessment, who is funding the development of this methods guide and why it is being funded, and possible future implications of that work. In part 2 of this recorded videos, spoke about a cost-benefit analysis of health technology assessment as a policy option, amongst others, to improve access to newer healthcare technologies. If you haven't listened to those two videos, please be sure to go back and listen, and please leave your comments as well. After this video, you may also wish to have a look at part 4 of this recorded videos, which is addressing technical aspects embedded within this document related to health technology assessment. So having said that, let's jump straight into looking at supply and demand. I want to first look at the demand side of the equation, in the sense that the introduction of this methods guide and formalizing health technology assessment system in South Africa will drive demand for health technology assessment skills or health economic expertise at several levels. So I want to talk about this demand component of this economy on this end, and then I want to reflect as well on the supply component. So who precisely is going to be doing this work? Where are they located? What are the and then if you take the demand and supply, what are the potential future implications? And I have a couple of proposals to share with you today that may address the imbalance between these two over here. So let's talk about the demand for health technology assessment, and it'll be initially apparent when the following comments are being made. So for example, under the section of systematic review, if a formal systematic review of the clinical evidence for the technology is required, it should be commissioned from a reputable research unit with researchers experienced in conducting systematic reviews. Now, the document doesn't provide us any clues on what a reputable research unit is. Is it referring to academic institutions in South Africa? If so, I think that should be explicitly stated where the capacity currently is to be able to do that. And are there agreements, for instance, between those local South African academic institutions and the Essentials Drugs program? Or is reputable research unit defined very broadly to potentially include as well outsourcing of systematic reviews to academic institutions in England and United Kingdom, broadly speaking? So so this would create a significant demand for systematic reviews. And just to kind of illustrate this point a little bit further, is systematic review, there's a rapid review option and there's a systematic review option. Rapid review will take about 5 weeks, and here you are contracting or employing an individual to be able to do this work, and this is fairly quick. However, with a systematic review, it could take up to 2 years, as short as 6 months to get done. So this is considerable resource or capacity that's required to undertake this type of work, and will be driving demand. I'm curious where that demand is going to go to, and how that supply is going to be met. Another example of the demand side of the equation relates to this part over here, which speaks about in the opening paragraphs of the document under forward, here, that the guide can be used by anyone, but more specifically that there may be contracted external reviewers that are involved in the assessment, the appraisal phase, coordinating management, and presumably adding additional capacity to the Essentials Drugs program. We're not sure what these contracted external reviewers are. And the same point that I mentioned a little earlier is, are these domestic expertise that are going to be used, that is academic institutions in South Africa, and if it's not academic, perhaps private independent consulting firms? Or is it referring to outsourced contracts with external reviewers based in England through the funding that will be provided by the Better Health program? So it's unclear what this refers to as contracted external reviewers. Another example of potential demand for this work is mentioned on the following page. Again, in the section where we're at the moment is evidence appraisal, kind of the intermediary step after having done the assessment. Under the current process, EDP Secretariat and contracted external review experts, again the same term being used here, such as eliciting HTA technical reports from manufacturers or consultancies. So this is a different point. But this point here specifically, again, it's unclear who's going to be doing this work, but there's clearly a demand for undertaking the current process of the appraisal, and potentially that is going to be outsourced to external parties. Again, is it domestic or is it international? Another case in point to kind of illustrate the level of demand for these expertise is the following. This is Table 1, Stage 2 Additional Analysis. It's identifying the clinical assessment, rapid systematic review, systematic review. I've already covered this a little earlier on when I spoke about the time that is required to undertake this. So 12 months of employing a person or a group of individuals to do this work. If you're doing a rapid review, 3 to 6 months. A little bit further down are other estimated timelines: cost comparison analysis, 1 to 2 weeks, rapid review of economic evaluations, 1 to 2 weeks as well, basic cost effectiveness analysis up to 6 months, comprehensive greater than 6 months, pricing analysis, and bespoke approach where you're customizing based on variables, budget impact analysis up to 2 weeks. This seems to be a little short in our view. But anyway, these set of services and activities under the health technology assessment system is going to create a significant demand for expertise. Another example is this one over here that we've kind of touched upon indirectly, but Table 3, methods for brief versus standard technical reports, 1 to 2 weeks for its production versus standard technical review, 3 to 4 weeks, and the expectation of the minimum requirements are all listed over here. So again, the same point, expertise are required to be able to undertake this work. And I've already spoken about this example under systematic review. There's a key issue though is in building capacity to do the health technology assessment is avoiding duplication, and the point is made in the document that there may be duplication in effort. This specifically refers to a systematic review undertaken recently in England, Italy, France, and Germany on the same intervention, medical device or medicine, is not going to be terribly different from one country to the next. Perhaps there may be local studies or local inputs with local epidemiological information that will be included for important for inclusion in that systematic review, but it's not going to be very different. So it certainly wouldn't be very productive by duplicating or reinventing the wheel if a systematic review has already been done in another jurisdiction where it could quite easily be applied within the South African context. So this focus on potential duplication could also reduce the need for additional capacity, and rather being a little more efficient in identifying where a recent systematic review was done in other jurisdictions and applying it or localizing it for use domestically in the South African market. So having said that, let's talk about the supply component, and it's a little silent on, not a little, there's simply no details included inside of this methods guide on how the demand for these expertise are going to be supplied. Now, I acknowledge that the purpose of the methods guide is to talk about methods per se, on how to do that. It doesn't speak about necessarily in great detail of who is going to do that, but I think this is a missing piece in the health technology assessment system that is proposed. The only mention in this guide is on the point of capacity, which is this point over here, 8. Leadership is recognized as a critical requirement for a successful HTA system. Okay. HTA processes in South Africa should incorporate the governance, sustainable funding, and capacity strengthening components required to develop and support leadership. Now, this capacity strengthening component is arguably the other half of a health technology assessment system. You can talk about methods, but if those methods are not being applied by a certain who or a group of individuals, then the entire system falls apart and goes absolutely nowhere. And this relates back to what we discussed in video 1, and the idea of approaching this health technology assessment methods guide and the demand for HTA. What impact would it have on skills development? And if you see it through two different lenses, in the first video I spoke about decolonization. As far-fetched as it may seem, the perspective of those that harbor or have those opinions would propose that building capacity entirely domestically within South Africa to ensure independence in health technology assessment would be a critical component and an important objective to achieve immediately to address the power imbalances in HTA systems between the global north and global south. If you haven't listened to that video, please go back to it and be certain to have a look at it. The other perspective was that based on meritocracy. NICE in England, for example, have developed exceptional expertise over the decades in applying health technology or in developing a health technology system and building a network of expertise and capacity around those institutions to be able to fairly efficiently apply assessment, appraisal, decision-making components in the continuum of implementing HTA. So, and if you look at it from the perspective of meritocracy, it makes absolute sense that South Africa would want to learn from HTA agencies in international jurisdictions to be able to build internal capacity. And perhaps somewhere in between these two extremes in thinking about HTA capacity building is where the National Department of Health may be thinking at the moment. But I would argue a little further to say that this HTA system over here is not viable and is certainly not sustainable at all if it is not accompanied with a capacity development plan or skills development plan. Case in point is trastuzumab was introduced into the South African EML in 2017. This was a full 2 years after it was already included in the World Health Organization EML. The work on a cost-effectiveness analysis to motivate for trastuzumab inclusion in the EML was outsourced to a university in the United Kingdom. Universities in South Africa, despite having current capacity and skills to be able to undertake that work, were not engaged and were not used. And I think this is a terrible disservice from the National Department of Health to academic institutions in South Africa and also independent consulting firms in not using capacity that currently exists. But I do see the perspective as well in perhaps learning from international markets and seeing how those methods are applied for implementation locally. So that's an example of how that outsourcing of health economic skills and technical analysis was done. A few proposals related to this discussion about supply and demand. First is, as I've already mentioned, in implementing an HTA system, one needs of necessity a skills development plan, capacity development component, this area over here, that would accompany the methods guide. And this is identifying a budget that's been set aside to be able to fund these activities and building those linkages with local academic institutions. Capacity at Wits University, for example, if it exists. University of the Western Cape, if it exists. UCT, if it exists. UKZN, if it exists. And local stakeholders will be far more familiar with where the capacity currently resides. I propose that in building capacity, the Better Healthcare Program, out of the funds of £80 million that have been set aside for supporting various countries, including South Africa, that the Better Health Program over the next 5 years fund at least 4 chairs of health economics at academic institutions in South Africa. Furthermore, that the Better Healthcare Program fund 10 PhDs in health economics over the next 5 years. And further to that as well is that the Better Healthcare Program fund 45 master's degrees with a specialization in health economics from local institutions or international to build those expertise domestically within South Africa. Based on that commitment from the Better Health Program to building capacity, only then will we have a more meaningful and sustainable implementation of health technology assessment in South Africa. The last point that I want to end on very briefly here relates to these official recommended health technology assessment agencies. Official websites of recommended HTA agencies. This was under the section of Summary of Health Technology Assessment Decisions. So when a new technology is being proposed for implementation, which countries would one have a look at? So England is top of the list, Canada, Scotland, Australia, Thailand, European EU NETA work, and they're doing really fantastic work on joint assessment reports and publishing these. And also international databases. But these are not the only HTA agencies that are out there, and there are arguably better HTA agencies in other jurisdictions that are doing far better work. France, for instance, HAS, is doing fantastic work in assessing newer health technologies, and in some instances a little bit more pedantic compared to England and Canada and other markets. Germany also does fantastic work. So does Italy. Case in point is in oncology, where the extensive patient registry that they use to facilitate outcomes-based reimbursement modeling and outcomes-based reimbursement within the Italian system. Likewise, Spain does great work, so does Japan, and so does South Korea. So those are not your traditional Anglophone a group of countries that rely on recommendations from NICE in the UK, but they are nonetheless independent, and they do publish interesting and regular HTA decisions on newer healthcare technologies. And I should also add to that list Norway, the National Institute of Public Health, that also do great work. An initial response may be that, well, those countries don't speak English, and you may be surprised that if you do a search of their web pages, some health technology assessment reports are published in English, and if you reach out to some of those HTA agencies, they would be more than willing to assist in explaining their decisions, because a lot of the individuals that have been trained in those institutions do speak English and are willing to articulate the rationale and the methods that they're used. So in the future, in building capacity and linkages with international institutions, it would also be important to reach out beyond just simply Anglophone group of countries and look at HTA decisions that have been utilized and are applied in other jurisdictions. So having said that, thanks so much for listening. I appreciate it. The purpose of this video, in summary, is to talk about the supply and demand of health economic expertise as an essential component in a sustainable long-term future of an HTA system in South Africa. Thanks so much for listening. Take care. Bye.